Good evening, everybody. We welcome you to the series of ESI webinars on gender-specific topics. This week, we are discussing one of the most commonly debated topic about one of the in endocrinology, that is the obesity, and what are the gender differences per it. I mean, right from childhood, it is taught to us that the females have more fat than the males, and there are some hormonal reasons for it, and there are some genetic reasons to it. So all these things are actually, do they cause any differences in the outcomes, or are they destined to be like that? Or what are the implications of these? To discuss all these, we have thought of conducting this seminar on gender differences in the obesity. To conduct these proceedings, I now invite Dr. Arpandev to conduct the proceedings. Dr. Arpandev sir is a senior endocrinologist from Bangalore, and he is the scientific committee chairperson of the ESICON 2020, which is going to be happening in Bangalore next year. Over to you, sir.
Namaskar, good evening. Welcome to our special webinar, and thanks very much, Dr. Hari Kumar and all of our ESI team bringing us in the platform, so that not that we are just going to moderate something, we are here mostly to learn. So today's topic, we have the gender differences, obesity, but let me go step by step. Let me welcome and introduce Dr. Dinesh Kumar Dhanwal as the co-chairperson for today's webinar. Dr. Dinesh is the head and the consultant in diabetes, endocrinology and metabolic disorder in NMC Specialty Hospital in Abu Dhabi, and he's also the former director professor of MAMC in New Delhi. While in Southampton, he received the Commonwealth Fellowship. He is a fellow of American Association of Clinical Endocrinologists, that is called AACE. He received the A.V. Gandhi Award for Excellence in Endocrinology, and also the Young Investigator Award from the Japanese Society of Nuclear Medicine and others. He has more than 50 PubMed indexed publications. Welcome, Dr. Dinesh. Dr. Dinesh is joining us from Abu Dhabi. Dr. Dinesh, we can have a quick opening remarks from you about today's topic. You please unmute yourself and start talking.
Thank you very much, Dr. Bhattacharya, and my thanks go to Executive of Endocrine Society of India for conducting this very important topic. See, this looks a bit unusual topic, but in our clinical practice, very, very important. I'll tell you about UAE, where I practice and live. Here the expat population, if you like, the proportion of men is more than women, because most of the people working class is here. So we find more obese people among men, and young children. Obesity is highly prevalent here. Diabetes, type 2 diabetes prevalence is 17%. Expats, South Asians around 18 to 20%, which are all harboring. And obesity, as you know, is harbinger of all these metabolic disorders. So I think let us go straight to the quiz and then talk, and then in the end we'll discuss again. So back to
yeah, thanks, Dr. Dinesh. So the proceeding will be like this. First, we'll have some quiz, and then we'll have the talk, and then we'll come back to the discussion and the quiz answers. And sincere request, please put your question to the chat box. It will be easy for us to pick them up. So it's now my pleasure to invite our PG, DMPG from Andhra Medical College, Dr. A.S.L. Shagar Reddy. It's wonderful, Shagar, that in your training period, you are getting an opportunity to do this type of meeting. We never got this in our time. Welcome, Shagar, and you can start your quiz.
Yes, sir. Sir, my slides visible?
No. Not till now, but you have shared, that's what it is coming.
You have to open the slides. Sagar, you have to open the slides. You click on the share the screen, then click on the slides.
Now, sir?
No. You click on the slides. Presentation.
Yes, sir.
So like how you are done during dry run, no? Just refresh on desktop once and open
Yeah,
keep the PPT open.
Now, sir?
Yes.
Yes.
Okay. Thank you very much, sir. Good evening, everybody. Respected professors, esteemed endocrinologists, seniors, and my colleagues. It's a great honor to conduct quiz on such an esteemed platform. So the quiz will contain 10 questions, 9 MCQ format, and 1 spotter. And each correct answer will carry 1 point. And I request all participants to note down the correct options separately and to answer all the questions at the end of the quiz in the chat box with respective questions in a single go. And entries till 4:30 p.m. will be accepted. And 3 winners with maximum points will be announced at the end of the session. So all the best to everyone. And so let's start the quiz. So the first question, waist circumference cutoff for Indians are. I repeat, waist circumference cutoffs for Indians are: option A, men 102 centimeters, women more than or equal to 88 centimeters. Option B, men more than or equal to 94 centimeters, women more than or equal to 80 centimeters. Option C, men more than or equal to 90 centimeters, women more than or equal to 80 centimeters. Option D, men more than or equal to 78 centimeters, women more than or equal to 72 centimeters. So, to next question. Question number 2. Most common cause of monogenic obesity is: option A, MC4R mutation. Option B, PCSK1 mutation. Option C, SIM1 mutation. Option D, leptin receptor mutation. I repeat, most common cause of monogenic obesity is: option A, MC4R mutation. Option B, PCSK1 mutation. Option C, SIM1 mutation. And option D, leptin receptor mutation. Question number 3. All of the following gut hormones are anorexic agents except: option A, ghrelin. Option B, cholecystokinin. Option C, peptide YY. Option D, GLP-1. I repeat, all of the following gut hormones are anorexic agents except: option A, ghrelin. Option B, cholecystokinin. Option C, peptide YY. Option D, GLP-1. The fourth question. Hypocaloric feeds reduces the energy expenditure in obese by. I repeat, hypocaloric feeds reduce the energy expenditure in obese by: option A, 6 kilocalories per kg of lean body mass. Option B, 8 kilocalories per kg of lean body mass. Option C, 10 kilocalories per kg of lean body mass. Option D, 12 kilocalories per kg of lean body mass. So question number 5. All of the following are true except: option A, obesity is associated with increased risk of colonic carcinoma in males. Option B, obesity is associated with increased risk of prostatic carcinoma in males. Option C, obesity is associated with increased risk of breast carcinoma in premenopausal women. obesity is associated with increased risk of cervical carcinoma in postmenopausal women. I repeat, all of the following are true except. So option A, obesity is associated with increased risk of colonic carcinoma in males. Option B, obesity is associated with increased risk of prostatic carcinoma in males. Option C, obesity is associated with risk of breast carcinoma in premenopausal women. Option D, obesity is associated with increased risk of cervical carcinoma in postmenopausal women. So question number 6. Each 5 BMI unit increase is associated with a rise in total mortality, mortality from chronic kidney disease, and mortality from type 2 diabetes mellitus by. So I repeat, each 5 BMI unit increase is associated with rise in total mortality, mortality from CKD, and mortality from type 2 diabetes mellitus by. Option A, 30% rise in total mortality, 60% by CKD, and 120% by type 2 diabetes mellitus. Option B, 15% rise in total mortality, 30 by CKD, 60 by type 2 diabetes mellitus. Option C, 10% rise in total mortality, 20% by CKD, and 40% by type 2 diabetes mellitus. Option D, 5% rise in total mortality, 10% by CKD, and 20% by type 2 diabetes mellitus. Seventh question. So which of the following is true regarding estrogen effect on adipose tissue? Option A, reduces lipoprotein lipase mRNA expression. Option B, reduces hormone sensitive lipase activity. Option C, reduces adipocyte precursor proliferation. Option D, increases leptin secretion. I repeat, which of the following is true regarding estrogen effect on adipose tissue? Option A, reduces lipoprotein lipase mRNA expression. Option B, reduces hormone sensitive lipase activity. Option C, reduces adipocyte precursor proliferation. Option D, increases leptin secretion. Eighth question. All of the following are true except. Option A, obesity causes hyperandrogenemia in females. Option B, ovaries develop insulin resistance in obese females. Option C, pituitary retains insulin sensitivity in obese females. Option D, obesity is associated with increased 17-beta-HSD activity in adipose tissue. I repeat, all of the following are true except. Option A, obesity causes hyperandrogenemia in females. Option B, ovaries develop insulin resistance in obese females. Option C, pituitary retains insulin sensitivity in obese females. Option D, obesity is associated with increased 17-beta-HSD activity in adipose tissue. So ninth question. All of the following statement regarding biochemical profile of premenopausal women compared to age and BMI matched men are true except. I repeat, all of the following statement regarding biochemical profile of premenopausal women compared to age and BMI matched men are true except. Option A, women have higher HDL cholesterol levels. Option B, women have lower LDL cholesterol levels. Option C, women have lower triglyceride levels. Option D, women have higher fasting insulin levels. So the last question is a spotted. A 3-year-old female child presented with obesity, red hair pigmentation, adrenal insufficiency. So please answer the diagnosis. So I request all participants to type the correct options with question number in a single go in the chat box, and entries will be accepted till 4:30 p.m. and the winners will be announced at the end of the session. Thank you, sir. Over to you, sir.
Thanks, Shagar. And you can stop sharing your slide. Yeah.
Yes, sir.
Thanks, Dr. Shagar. It's wonderful. I don't know what Dr. Dinesh is thinking, but I am thinking I'm glad that I'm not participating in the quizzes. Thank you very much. Now it's over to Dr. Subramaniam. Dr. Subramaniam is professor and head of the Department of Endocrinology in the same medical college. Actually, Shagar is the PG student of Dr. Subramaniam. Dr. Subramaniam, over to you.
Thank you, sir.
Yes, we can see your slides. Yeah.
Thank you. Good evening, Dr. Appan and Dr. Dinesh. And I thank Endocrine Society of India for giving us this opportunity to interact at this moment. And after yesterday's starting of grand website inauguration ceremony, I think this is a good thing is going on in the Endocrine Society of India. And I thank the organizers, especially Hari Kumar, for giving me this opportunity. And regarding the topic obesity and gender differences, till this time of preparation, I was thinking that obesity is almost, as Hari mentioned, that slightly different from the males and the females, and it is much more in the females. More than that, I thought not much of differences. But when you look at, there is a change in the attitude, as I'm going to show in the penultimate slide, what people think about the obesity between the sexes. So coming out to the skin, you can see here that so you can see here when the fat is deposited in the subcutaneous tissue under the skin, and with more and more eating and the deposition of the fat, you can see more and more fat is being there, and gradually it increases. Still it is in the subcutaneous layer only, and with more fat, the thickness of the fat in the subcutaneous tissue increases. Then of course, then with more fat, then probably it is going into the dermis also. So till that time, it is only located in the subcutaneous region. Now it is approaching and entering into the dermis. So wherever there is a space, the fat is going to be there, and it is going to deposit if the person is not consuming much more than the what he is spending. So with this, we have two types of fat, and that's what we are discussing throughout: subcutaneous versus visceral adipose tissue. And this is how the person's fat tissue, both in the subcutaneous regions as well as in the visceral adiposity, increases, and with much more, it still grows up. This is the progression as far as the fat is concerned. So looking at the differences between the subcutaneous adipose tissue versus visceral adipose tissue, the subcutaneous adipose tissue, the total lipid synthesis is more in the women when compared to the men. Whereas in the visceral adipose tissue, the rate of lipolysis is low. So this is the basic difference between the subcutaneous adipose tissue and the visceral adipose tissue. So this results in more of subcutaneous adipose tissue in the women when compared to visceral adipose tissue. And these increasing volumes of this adipose tissue were consistently and strongly associated with more adverse risk factors in the women when compared to men. So this is much more important and more adversely related in the women. You can see in this Framingham Heart study where the cohort showed that there is a differences between the women and the men, both in the deposition, the subcutaneous adipose tissue, and the visceral adipose tissue, and all these metabolic parameters. If you take the triglycerides, HDL cholesterol, total cholesterol, systolic BP, blood glucose, and physical activity index, you can see that they're almost significantly associated, and the risk is much more in the women when compared to the men. So coming to the prevalence, so this is a WHO study where according to the regions, the comparison between the overweight individuals between 1975 and 2016. Here you can see that in Southeast Asia, you can see that the male had a prevalence of 4.7% and female 7% in 1975. Over these 40 years, you can see the incidence has gone up tremendous, and still females are leading and males are trying to catch up the obesity. Sorry for this poor quality of the slide, But when you look at the trends in the obesity, when the males, when they attain puberty, the adiposity goes up and obesity increases. And gradually, when they reach by age of around 65, 70, you can see this reduction in this obesity. That's what we can see. This is from the Korea. And whereas in the females, you can see till the age of around 35, 40, their fat status is stable. And then the prevalence goes up gradually post menopause and almost till the age of 70 years, then it plateaus. So the obesity trends are gradually increasing. It depends upon the time period during their life. And when you look at throughout life, females have more fat when compared to the males. And even before puberty also, girls have more fat. So that's why we think not only the hormones, the genes or the chromosomes have an effect over the deposition of the fat in the females. When the males approach the puberty, they have more tendency to have central fat deposits when compared to females. So during puberty, males tend to have more amount of central fat. So we can think that this can be due to the hormonal influences during the puberty. Whereas in the post-menopause, women start developing more of central fat and consequently more of metabolic problems and disturbances. So the main thing is the adipocyte. And the adipocyte, actually, initially when the person starts eating more and depositing more, the fat cell weight increases. Then gradually the fat cell number increases. That's what we can look at. So both the fat cell weight initially increases, accommodating more and more of fat, then the fat cell number. When you look at the size of the adipocytes, in women, the omental adipocytes are smaller than those in the subcutaneous adipose tissue. But when you compare between the men and the women, the adipocytes are smaller in the women when compared to the men. So these are the basic differences in the adipocyte size between the subcutaneous adipose tissue and fat adipose tissue and between the males and females. So as far as the functions and the metabolism of adipocyte, we can deal with these headings. So what happens to the free fatty acids regarding the triglyceride synthesis and metabolism? What is the activity of lipoprotein lipase? And of course, the adipokines which are being secreted, the levels of adiponectin and leptin, how these are being influenced in both the males and females. Coming to the adipocyte metabolism, with more and more when the patient or person eats food, then the triglycerides they circulate in the blood. There they are being metabolized by the lipoprotein lipase under the influence of insulin, then releasing the free fatty acids. These lipoprotein lipase mediated released free fatty acids, they enter the adipocytes and the lipid droplet, increasing the size of the lipid droplet. Not only the lipoprotein lipase mediated released fatty acids, but the free fatty acids which are circulating in the blood also, they enter the lipid droplet. So there are two sources. One is from the meal derived, and the second one is the free fatty acids which are circulating in the blood also. They enter the adipocyte and being synthesized into the triglyceride. Whereas the catecholamines by both adipocyte triglyceride lipase as well as hormone sensitive lipase under the influence of catecholamines and of course the disinhibition from the insulin causes triglyceride lipolysis and releasing the fatty acids. But here you can see most of the times that I already mentioned that in women, the lipolysis in the visceral adipose tissue is less. That's why the release of free fatty acids from the visceral adipocyte will be less in women when compared to the men. So coming to the activity of the lipoprotein lipase, the subcutaneous adipocytes from the women have higher lipoprotein lipase activity and triglyceride synthesis. And of course, they also have insulin stimulated glucose uptake compared to the men. So all these activities, whether lipoprotein lipase activity, triglyceride synthesis, and glucose uptake are more in women when compared to men in subcutaneous adipocytes. So coming to the sex differences, you can see that the leptin and adipotectin levels are more in the females, whereas the meal-related fatty acid uptake is more in the males. This is the so-called apple and pear-shaped fatty acid, fat deposition in the males and females, the famous diagrams. So what happens after food intake in the lipid or this metabolism? So when you look at the meal-derived fatty acids, this uptake is more in the visceral adipose tissue in the men when compared to the women. So when men take more fat tissue, fat or food, then probably the more and more fatty acids will be entering the visceral adipose tissue and deposited at the triglycerides when compared to the women. The differences in the free fatty acids entry into the adipocytes in the males or females after meal is likely to contribute to the increase in the visceral adipose tissue in the men. So the diversion. So more of free fatty acids are diverted to subcutaneous adipose tissue in females, either in the thigh area or gluteal area, whereas in the males it is more diverted towards the deposition in the visceral adipose tissue. So these are the differences which happen, and that's why there are differences in the deposition of the adipose tissue in the subcutaneous regions in the femoral or gluteal regions in the female, and abdomen and visceral adipose tissue in the case of male. So coming to the adipokines, both there is increase in the leptin and adiponectin in females. This increase might be due to inherent deposition in the adipocyte function between the sexes, may be related to chromosomes or genes, or probably the differential regulation by the hormones. So coming to the various metabolism, coming to the glucose metabolism, you can see during fasting, the glucose levels are lower in women when compared to men. Whereas after exercise and hypoglycemia, the glucose oxidation is higher in the men. So men depend on the more of carbohydrate metabolism for their energy sources, while females it is not so. Even the hepatic glucose production is less in the females. That's why probably the glucose levels are lower in women after fasting. So look at the lipid metabolism. We have the fasting, exercise, and hypoglycemia. During all these states, there is increase in the lipolysis with increased release of free fatty acids in the women. These free fatty acids are oxidized in the liver to ketones, and these excess free fatty acids that are being released from the lipolysis, or they undergo the non-oxidative disposal. That means they are stored as triglycerides. So the more and more free fatty acids are being synthesized and diverted towards triglyceride synthesis in the women when compared to the men. That's why women have more amount of fat when compared to the men. And in toto, we can see that the women are more dependent on the lipid metabolism as far as lipid metabolism, whereas men depend upon the carbohydrate metabolism either normally or during the times of stress, whether fasting, hypoglycemia, or exercise. That's what there is a great general difference between the women and women. Coming to the lipoprotein lipase, the lipoprotein lipase enzyme activity as well as the lipoprotein lipase mRNA levels are significantly higher in the women than in the men. So naturally, the enzyme activity in the abdomen is much more in the girls. So when compared to the gluteal regions. So when the enzyme activity is more in the abdominal region, and more free fatty acids will be going and depositing, as well as more and more free fatty acids will be released from the fat, resulting in the so-called metabolic problems as far as fat tissue is concerned. Looking at the both sexes, you see the lipoprotein lipase mRNA levels are threefold higher in the abdominal area as compared to the gluteal site. So this may be due to the gene expression as well as the post-translational modification. That's why more amount of lipoprotein lipase activities there in the abdominal adipose tissue. Probably that's why more amount of free fatty acid release and the so-called metabolic side effects. So you can see this cartoon, you can see that both during hypoglycemia, during exercise, you can see the autonomic nervous system activity is much more in the males. Likewise, release of pancreatic polypeptide, glucagon is also much more in the males when compared to females. And consequently, there is increase in the hepatic glucose production. And in the muscle, there is increase in the glycogenolysis. Whereas you come to the lipid metabolism, you can see the release of glycerol and free fatty acids are more in the females. So this is female and this is male. You can see that lipid metabolism is much more preponderance in the females, whereas the carbohydrate metabolism and related hormones in the males. So that's what you can see. This is from hypoglycemia or during exercise. These gender differences can be due to genes, or they can be due to hormones, and environment can also influence these gender differences. Whereas there can be difference in this gender in the treatment response also. So let us see how it happens. So coming over to the genes, it could be the chromosomes. The X chromosome itself can divert these compartmentalization of this adipose tissue and fat deposition between the males and females. So you can see in this Framingham heart study, the heritability of subcutaneous adipose tissue is almost 57%, whereas heritability of visceral adipose tissue is 36%. So both the tissues, whether subcutaneous or visceral, it was shown that they're heritable. That's why you see the similar shapes in the family between the ladies and the males. That's what you see. And coming to the polymorphisms, you can see these are the various polymorphisms which are being implicated in the obesity and the differences between the men and the women. But here you can see these two polymorphisms related to waist hip ratio. They are not significant in the women, whereas they are significant in the women. So they are not significant in the men, but they are not significant in the women. So you look at the these two polymorphisms, RS987237 and this one, you can see that though they are both significant in men and women, but the difference you see, there's not much difference between the men and women. So there are lots of polymorphisms. I've shown only some, but there are a lot of polymorphisms which are different in males and females, and probably they are directing the fat deposition and consequent metabolic effects. So coming to the hormones, we have estrogens, androgens. Of course, we have adrenal axis, and we have also higher CNS centers. And estrogens and androgens, we know that estrogen receptors are more present in the gluteal adipocytes in the females. That's why more and more fat deposition in the gluteal region as well as in the femoral region in the females. And they found out there is a positive association between estradiol and visceral fat in both the sexes, not only females, so both the sexes. And the higher the bioavailable testosterone, they are associated with higher fat and also SAT in the women. So higher bioavailability, actually till this time we thought of that more and more fat, more and more adipose tissue, more of T is there as we see in PCOS, but reverse is also true. And higher DHEA was associated with higher visceral fat again in women, but not in men. So DHEA we can look at in this way. So this is also androgen, probably that may be related to visceral fat more, whereas higher SHBG is associated with significantly lower levels of adiposity in both the sexes. So SHBG is a good one as far as fat deposition and the adiposity is concerned. So looking at the actions of estrogens, estrogens stimulate the proliferation of human pre-adipocytes. So pre-adipocytes are more and more number under the influence of estrogens, whereas androgens inhibit the differentiation of these adipocytes, but without affecting the proliferation. Proliferation, they won't do anything, but whereas differentiation, they inhibit the differentiation of these pre-adipocytes into adipocytes. So that is the difference between the effect of estrogens versus androgens. Whereas androgen excess plays an important role in the expansion of visceral fat. That's important. That's why you can see that in PCOS, probably androgen excess leads to more amount of visceral fat. That also we can see. Of course, in the males, the same thing is seen where testosterone levels are more and more is the visceral adiposity. The testosterone suppresses the lipoprotein lipase in the femoral fat, prefers fatty acid accumulation in the visceral fat in the men. So this differentiation is there. So probably because of more testosterone in the males, the femoral fat is less and visceral fat is more. So that also we can see when we look at the effect of these hormones. And the correct effect of these hormones can be known in transgenders because transgenders, especially trans women, you can see that they are given estrogens, probably what is the effect they will have. So those people who are on estrogens had a higher body fat than males. That means males means the male persons you see, they have higher body fat. So once they are started on estrogens, their body fat content increases and they have more body fat than the females. Whereas the fat is less than the females in the control group. So you can see, so they're in between. As far as the fat is concerned, once they are started on estrogens, they have higher body fat than the males, whereas lower than the females de novo. That means their estrogen is acting and causing more and more deposition of fat, or probably entry of more and more fatty acids into the adipocyte and increasing the adipocyte depots. So this is another study published in 2020, actually, Journal of Clinical and Translational Endocrinology, where they have seen the effects of gender-affirming hormone therapy on body mass index in transgender individuals. So when they looked at, they found that BMI significantly increased in trans women, but not in trans men. So trans men, they are on testosterone, so there is not much of increase. Whereas in trans women who are on the estrogens, the BMI significantly increased. This is what they found out. So coming to the adrenal axis, they found that the urinary free cortisol excretion rates are significantly higher in those patients who have abdominal body fat deposits more than the peripheral body fat deposits, and of course, then the control women also. So free cortisol excretion rates are higher. But when they looked at the response to CRF and the ECTH, they are similar. So they hypothesized that obese women with the abdominal uh, body fat depots have either hyperactivity of the hypothalamic pituitary adrenal axis, resulting in more amount of urinary free cortisol excretion rate, or probably secondary to a state of functional cortisol resistance. That's how they hypothesized. So the adrenal axis is probably much more hyperactive, or probably there is a secondary functional cortisol resistance. Coming to the activity of autonomic nervous system, they have, during exercise, they found that men have increased autonomic nervous system activity, either the release of epinephrine, norepinephrine, or pancreatic polypeptide, and the effects on cardiovascular system also, increase in the systolic pressure or mean arterial pressure, and certain metabolism of carbohydrate oxidation and counter-regulatory responses. These are all more in the men. So there is increased activity of autonomic nervous system in the men during exercise or hypoglycemia, which is the picture I've shown in the beginning. But when you look at the women, they have increased lipolytic activity, that is more of glycerol, more of free fatty acids, and more of ketogenic responses. So there is an entirely different thing, probably whether they have a resistance to sympathetic activity of various hormones at the level of CNS, that we have to see. So this is a beautiful picture proposed by Jagang et al., where they can see the insulin and leptin. These are the hormones which continuously stimulate the POMC neurons, and this alpha MSH, this stimulates the MC4 receptor in the paraventricular nucleus, and subsequently more of sympathetic nervous system activity. Whereas in the females, this doesn't happen, and that's why not more of stimulation of paraventricular nucleus MC4 receptors, and of course the balance between the NPY activity and the POMC alpha MSH is same. That's why the increase in the sympathetic nervous activity is less. Here also you can see that the estrogens reduce the inflammation, which can increase the activity of POMC neurons. And also you can see the influence over the angiotensin 2 also. So somehow at the CNS level, at the hypothalamus level, the hormones influence the activity of these POMC neurons and MC4 receptors in such a way that more amount of autonomic nervous system activity is present in the males, and it's not so in the females. So this is an important experiment where they wanted to see if after liposuction, or if the fat is removed surgically, what happens to this fat and where it returns. So this is a publication Obesity 2011, where you can see that after following suction lipectomy, that means they removed the fat tissue suction from the femoral region, and observed 6 months and 1 year and 2 years, it was shown that the body fat was restored. So you can see that after 6 months to 1 year, full body fat was restored, but there is a redistribution from the thigh to the abdomen. So this is most important, because the so-called peripheral fat has become now abdominal fat. So this is over 1 to 2 years. So this is very important, because those people who undergo liposuction, especially from the peripheral tissue, they should be very careful, because now that is going to become much more harmful visceral adipose tissue, and that is dangerous. So coming to the treatment differences between the males and females. So first we look at the exercise. This is very important as far as men are concerned. Regardless whether they lose weight or not, if the men do exercise, there will be a preferential loss of visceral fat. That is much more important. That's what is very important and also very surprising to me. So whether there is weight loss or not, men after doing exercise, they observed loss of visceral fat. So this is very important. Whereas if you look at the this one, aerobic resistant exercise, when men do it, there is increase in the fat free mass in the arms, trunk, and the whole body. And there is a decrease in the percentage of fat in the trunk. Whereas you look at the women, they respond differently. So they reduce only fat mass of the legs, not in other areas. So you see that in men, they increase the lean body mass in all the areas, whereas women, mainly they reduce the fat mass in the legs. So this is somewhat how the body responds to similar exercise between men and women. That is difficult to understand. So this is another important point. You see, the physical activity intensity has been inversely associated with fat loss in both men and women. So intensity of exercise is related to fat loss. Whereas the duration, you see, physical activity duration has been related to fat loss only in men, not in the women. Again, this is very difficult to explain, because the exercise or physical activity is calculated in toto. That means duration into the amount of activity. But here see, the intensity is related to fat loss in both genders, whereas the duration is related to fat loss only in the men, not in the women. So these differences, whether we attribute to the chromosome or environment, we don't know at this moment. So this is a beautiful meta-analysis by Nonnetti et al., which is published in the Journal of Obesity and Weight Loss Therapeutics. So the after behavior modification, whether it is a diet, exercise, or psychological counseling, you can see that there is somewhat so many studies are there. 16 studies reported no gender differences, whereas 16 studies found better weight loss in the men compared to women. This is very surprising again, because you can see this is a forest graph where they showed that men fared better as far as weight loss is concerned with behavioral modification, whether it is a diet, exercise, or psychological counseling. So looking at the surgical interventions, the same meta-analysis, looking at the surgical interventions, whether they are gastric bypass, there are so many types of gastric bypass, or gastric banding, or laparoscopic sleeve gastrectomy. So all these things are somewhat given different type of results in different studies. 6 studies detected better results for the men. That means they had better weight loss, whereas 6 other studies detected no gender differences. So at best we can say that the gender differences are not there. If at all they're better in the men. So this is regarding the weight loss. Coming to the weight loss maintenance, that is also very much important after either medical treatment or surgical. How many months or years or duration a person could maintain the weight loss, that is very much important. You see that the results between the gender for weight loss maintenance are even less conclusive. That means there are not much of gender differences. You can see that a majority, approximately 8 studies mentioning weight loss maintenance reported no gender differences. And another important point is only 3 studies reported better weight loss maintenance in the men, whereas 2 studies reported better weight loss maintenance in the women. So now we can see that probably we don't have a correct idea regarding whether the weight loss maintenance is better in the men or women. But at this moment, I think we can believe that there are no gender differences. Both are same. So this is the slide which I'm mentioning in the initial thing. The attitude of individuals is different. So men, we all believe that we are less concerned about weight, and the men consider weight and consent programs more of female realm. Females are much more interested and men are not interested. Men are much more concerned about weight and women are much more concerned about weight and disfigurement. They usually ask for our consultations. That's why we see more of women coming to our consultation as far as weight loss is concerned. And the weight loss and gain cycle is much more frequent in females that try, they lose some weight, again they gain. So that is much more frequent in the females, and males the data is very scarce. So with this, I think we found out there are significant gender differences in the deposition of the fat, adipocyte metabolism of the glucose and the lipids. And we also found that these differences can be due to genes or due to hormones, as we have looked at the estrogens and androgens, and of course environment. I didn't discuss much about the environment. And of course the metabolic consequences we have seen, whatever the fat deposition, females are much more detrimental. The metabolic consequences are much more detrimental in the females when compared to males. And of course, treatment related, the weight loss is difficult to achieve. Whatever it achieved, it seems that is better in the males in few scarce studies, whereas the gender differences are not much as far as weight maintenance is concerned. With this, I thank you all very much for patient listening. And I think as far as this gender is concerned, the data is not that much. So there are so much of data saying that this is the effects of estrogen, these are the effect of testosterone. We see that usually we are all concerned about obesity much rather than looking at the gender differences. And I think we should focus gender-wise, because whatever the fat deposition is concerned, the metabolic consequence is the same. And as we Indians, we are much more concerned about the visceral adipose tissue, simply because the body mass index is not much higher, but still the bad consequences are there. So whether we as an Indians, whether our women and the men have different metabolic profile and different consequences and different treatment related responses, we have to see in the future. Thank you, and thank you very much.
Well, thanks very much, Dr. Subramaniam. It's a very complex topic and very ill understood. You have raised so many positive points to take home message, and between basically the abdominal obesity and the gluteofemoral obesity for the male pattern and female pattern, particularly your last points on our Southeast Asian phenotype with so-called thin fat Indians. BMI is normal or abdominal obesity is more. This is one of the reasons probably that we see the atherosclerotic cardiovascular disease will be also more common in men than in women. This 4:30 was the time for our quiz submission of the quiz report. I hope everybody has done, but I would be at some point of time will request Dr. Shagar to tell the correct answer once you have gone through selected the top 3 winners. Dr. Dinesh, you can unmute yourself and let's have a comment, and let's see the chat box. What are the questions we need to answer from there? Dr. Shubhu.
Thanks, Dr. Subramanian. I think wonderful. This is a very tough topic, and you have really worked hard to present this, and you have brought out very important differences. And I hope this will garner more support from research in this area. And many of our DM students are listening to your talk, and there's a lot of scope to do research in this area, gender difference in obesity, and also impact. See, whether the impact is in form of metabolic diseases or atherosclerotic diseases much more, and also there's the importance of pre and post menopausal. As we know, pre-menopausal women are less predisposed for the atherosclerotic vascular diseases. But how much the role of fat and after menopause, these are important things to be known in future. Thank you so much. I really enjoyed your talk and learned a lot.
Thanks, Dr. Dinesh. So we are true, Shubhu, that we have gained a lot of knowledge about the gender difference from male to female and female to male. But what happens to, they see the male who take more of androgen, so for drug abusers to make the muscle mass and things. What happened to them? Do they get more abdominal obesity?
Actually, testosterone has differential effects in different people. That is a very important question. And actually, testosterone as you can see in the individuals, during the puberty with increase in the androgens, the visceral adipose tissue increases. But when you take testosterone for the purpose of in building the lean body mass, especially that is a supraphysiological doses or pharmacological doses, actually there is increase in the lean body mass, as we can see in all the individuals, and the visceral adipose tissue will not grow, will not increase at that moment. So that's why there is a free flow of increase in this testosterone, not only in the males, and the females also. I'm sorry to mention testosterone, all the androgens. That's what we see in the various formats, where the increase in the adipose tissue, especially visceral adipose tissue, is not observed. Even there is a decrease in the subcutaneous adipose tissue also. But here we can think of another point. Their workout is more, exercise is more. That's why probably we are not that much sure whether it is athletes or even the weightlifters also, the adipose tissue is not going up because their workouts and diet is different. Probably that could be the.
And from that point, when anabolic steroids people use for the same purpose, do you have a difference into male and female?
I didn't find anything regarding anabolic steroids because there are much of because see, these are not allowed. Usually they're not legal, so probably I don't find the data. But any anabolic steroid also will be the same thing. But here, whether the usage of anabolic steroid for short time versus long time, that is the most important thing you can see. In a short while, anabolic steroid would induce more of anabolic activity and the muscle activity and all these things. But longer duration, they have side effects. But nobody mentioned anything regarding any papers regarding the deposition of the fat on the fat as actually anabolic steroids. But actually, I wanted to ask you, in your own practice, when you look at, because see, after seeing only, I'm looking at my patients, see what are the differences.
That's right. I'm also thinking same thing.
That's what. When you look at this is for you as well as Dinesh, I see whether you observe any significant differences as far as the fat is concerned, adipose is concerned between the males and females.
But the females are more loss and gain cycle. This is probably right. Your last part of these things are very good. Males are really not much bothered about that. Females are much more bothered. That's why they keep on coming. Dr. Dinesh, you have a comment on this topic?
Yes, I think that's right. Men, when we bring it out, when we emphasize that your metabolic disorders, diabetes, hypertension is related, we have to really emphasize much more to men for their overweight and obesity than women. Women are generally, they will be looking for, even if they have a weight gain of few kgs, they will be coming to us and they want to lose some weight. And same thing with children. Now, I get frequently, at least now because of the holidays for children, at least I'm getting 4 or 5 children every week, and parents are bringing them for the obesity. I think so. This is another important aspect that people are getting more aware of obesity in children. And again, the differences are same. What in the pubertal changes, which what is Dr. Subramaniam discussed at the puberty, the pattern of fat deposition changes.
I think we all need to go back to our childhood when there was no WhatsApp was there, no internet there. We used to play football and cricket in the gully.
No, Dr. Arpan, in our childhood it's different. No, see, lots of time for play, little amount of time to spend with our TVs and mobiles, and even the food also. Sometimes I used to eat less and go out for play. So now it is entirely different. Along with the food, watching TV is going on, watching the mobiles is going on. So I think we have to have something as far as observation is concerned regarding the girls and boys, whether the obesity has a difference, because at that time the influence of hormones will be very less. I think that we can see.
Well, Shubhu, there's one question is there. This question is related to the cardiovascular risk. The question is this: do postmenopausal women have less cardiovascular risk compared to males? Postmenopausal women.
No, the postmenopausal women, they have the risk equal or more than the men, because their manifestation of metabolic consequences by estrogen is lost. So naturally, postmenopausal, all these things are lost. And you can see in the trends also, postmenopausal, the obesity has gone up, and as well as the visceral adiposity is much more gone up. So the related metabolic complications are much more. So the slide which I have shown. And as far as what I've seen, the interesting observation is that with increasing adiposity and the fat, the females have more cardiovascular risk. So equal amount of fat distribution between the males and females. Females have more cardiovascular risk. Till this time, frankly, I was believing that males used to have more amount of risk. But here the study shown clearly that females, that's a Framingham Heart study, the same cohort taken from the Framingham Heart, the Caroline et al., which is published in the Circulation, have shown the graph where metabolic profile is bad in the females with equal amount of the fat. That is what's surprising to me also. But yes, so this is there during the pre-menopausal period, and after menopause, of course, the beneficial effect of estrogen in the last, and naturally the metabolic consequences are bad.
And a quick comment before we are a little bit running short of time about obesity in Turner syndrome.
Obesity in Turner's.
Shubhu, obesity in Turner syndrome. A quick comment from you.
So I think I don't have an experience, but I think with increasing age, the fat is going to increase. Whether the supplementation of the hormones has an effect over it, sorry, I don't have a correct idea. Anybody has an idea, please let me know. But with increasing age, the same thing with Turner's also.
Sir, that's all, sir. So shall we proceed with the answer?
Okay, thanks very much, Dr. Shubhu. I think we'll go to Dr. Sagar now. Dr. Sagar, can you tell the correct answer and then the winner?
Yes, sir. Sir, my slides are visible, sir?
Yes. Visible, Sagar. Visible.
Okay, sir.
Yes.
Thank you, sir. So first I'll let the correct answers. Okay, the first question was the waist circumference cutoff for Indians. So the correct answer was men more than or equal to 78 centimeter, women more than or equal to 72 centimeters. So as we know, WHO has given criteria for Asia and Pacific region of 90 centimeter more than or equal to 90 centimeter for men and 80 centimeter for women. They do agree that Indians cutoffs are slightly lower than the proposed criteria. So in 2006, A. Mishra et al. Conducted a multi-site study where he said that waist circumference action level 1, that is men more than or equal to 78 centimeters, women more than or equal to 72 centimeters, corresponding to 21 to 23 kg per meter square BMI, and action level 2 more than or equal to 90 and more than or equal to 80 centimeters, corresponding to weight BMI of more than 25 kg per meter square. So this question was to say specifically that Indians have lesser weight circumference than what is proposed by the WHO.
Okay.
So coming to the second question.
Quickly, Sagar, we are a little bit short of time.
Sir.
Yeah.
So the most common cause of monogenic obesity is MC4R mutation. So we all know MC4R is a receptor for alpha MSH and also agouti-related peptide, by which it reduces or increases the food intake. So prevalence is 0.5 to 5.8% in childhood obesity and around 2.3 in adult obesity. Question number 3. So all of the following gut hormones are anorexic agents except. So answer is ghrelin. So we know that all the gut hormones are increase satiety, but ghrelin, which is secreted from the stomach in the fasting state, increases the food intake. Question number 4. So hypocaloric feeds reduces the energy expenditure in obesity by 8 kilocalories per kg of lean body mass. So this was identified by landmark trial by Rudolph et al., where he identified that when body weight was maintained 10% lower than the initial weight, so there was reduction in total energy expenditure also by 6 kilocalories in non-obese and 8 kilocalories per lean body mass in obese. And it was similar when it was tried to rise also. So he concluded that maintenance of reduced or elevated body weight is associated with compensatory changes in energy expenditure, which opposes the maintenance of the body weight. So these compensatory changes may account for poor long-term efficacy for treatment for obesity. Coming to fifth question, all of the following are true except. So obesity is associated with increased risk of colonic carcinoma in males is true. Obesity is associated with increased risk of prostatic carcinoma in males is true. Obesity is associated with increased risk of breast carcinoma in premenopausal women is false. And obesity is associated with increased risk of cervical carcinoma in postmenopausal women is true. So in males, obesity is associated with increased risk of neoplasm of colon, rectum, and prostate, whereas in women, it is in reproductive system, that is mainly breast and endometrium, and also gallbladder tumors. On contrary, increased adiposity is associated with reduced risk of premenopausal breast cancer, which was shown by Shoemaker et al. So coming to question number 6. So each 5 BMI unit increase associated with rise in total mortality by 30% and mortality from CKD by 60% and mortality by type 2 diabetes mellitus by 120%. So option A is the correct one. So this was a collaborative analysis of around 57 prospective studies, which included around 9 lakh population. So they saw that each 5 kg per meter square higher BMI was associated with 30% rise in mortality, total mortality, 40% by vascular mortality, 60% by renal, and 120% by type 2 diabetes mellitus. Coming to 7th question, which of the following is true regarding estrogen effect on adipose tissue? So estrogen, so as already sir has told, estrogen increases lipoprotein lipase mRNA expression, whereas estrogen decreases hormone sensitive lipase activity, decreases adipocyte precursor proliferation, and increases leptin secretion. So only option A is correct. So we know that estrogen decreases the lipogenesis, increases lipolysis, and increases adipogenesis, whereas it decreases the leptin secretion. So coming to question number 8, all of the following are true except. So obesity causes hyperandrogenemia in females is true. Ovaries develop insulin resistance in obese females is false. And pituitary retains insulin sensitivity in obese females is true. Obesity is associated with increased 17 beta HSD activity is true. So in obese females, insulin receptor in pituitary and ovarian cells stays sensitive in comparison to liver and muscle cells. And hyperinsulinemia at ovaries causes direct stimulation, leading to increased androgen production. Whereas hyperinsulinemia at pituitary level, initially through GnRH increases gonadotropins, and later once hyperinsulinemia is set, it causes large amount of LH secretion from pituitary, leading to further excess of androgen production. So coming to 9th question, all of the following statement regarding biochemical profile of premenopausal women compared to age and beyond matched men are true except. So option A, women have higher HDL cholesterol levels is true. Women have lower LDL cholesterol is true. Women have lower triglycerides is true. So women have higher fasting insulin is false. So the premenopausal women, when compared to age-matched men, have better lipid profiles. So they have higher HDL cholesterol, lower LDL, VLDL, and total triglycerides. But although fasting insulin levels are comparable between premenopausal women and BMI-matched men, women show improved sensitivity at the level of liver and skeletal muscle. So they have comparable insulin levels, but they have higher sensitivity compared to men. And 10th question, so 3-year-old female child with obesity, red hair pigmentation, adrenal insufficiency. The answer is congenital POMC deficiency. So POMC is a pro41 amino acid polypeptide, which is cleaved by pro-hormone converters into various peptides, that is MSH or ACTH or lipotrophins, endorphins. These act through melanocortin receptors, which maintain the weight and also cortisol secretion, also pigmentation, skin pigmentation. So this disorder is characterized by early onset obesity, adrenal insufficiency, red hair, and decreased skin pigmentation. So finally, we come to our winners. So first is by Dr. S. Ghosh from Kolkata. He got 6 answers correct. Second is Jeevan Pradhan from Kolkata. Katak, he got 5 correct. And Riaz RS Kolkata has got 5 correct. So I congratulate all the winners.
Good. Thanks very much, Sagar. I just, for listening to your quiz, I think all the best to your examiners. Whoever will be your DM examiner need to be really tight and asking good questions. Dr. Dinesh, any last moment comment before we hand over to Dr. Hari?
Yeah, Sagar has done very well, putting tough questions.
Thank you, sir.
Good to put tough questions because as I told earlier, a lot of our students are watching. So good, well done.
I will get only 3 marks, sir. If I answer correctly.
Okay, thanks very much. Dr. Subbu is wonderful to listen. Sagar, good luck to you. Dr. Dhanesh and myself, we are very grateful to USA for giving us opportunity. Now, I'm handing over to Dr. Hari Kumar.
Thank you. Thank you very much, sir.
Thank you, sir. Thanks for the excellent conduct of the program. Thanks, Subramaniam, sir, for an excellent talk and an overview. Completely, learned a lot of things. And quiz, as thankfully we are on the other side of the table, so we don't have to face any more quizzes. So that's the best part, I guess. Thanks for everybody, Dinesh sir and Arpan sir. Excellent conduct of the session. We hope to see you again in the physical meeting at ESICON Bangalore. I'm sure Arpan sir is eager to host all of us. So we shall be meeting soon. Have a great weekend. Thanks for joining us. Thank you.
Thank you. Thank you, Arpan. Thank you, Dr. Dinesh. Thank you, everybody.
Thank you, sir.
Thank you.
Thank you.